presentation is titled, What is Midwifery and Is It Right for Me? Our presenters are two awesome midwives. First, Jessica Braman. She's a certified nurse midwife with clinical interests in prenatal, intranatal, and postnatal care and education. And Stephanie Yaldoo, who is a certified nurse midwife and with clinical interest in labor and delivery, prenatal and postpartum care, well woman care, and pain management alternatives during labor. So welcome, ladies.
Thank you so much, Allison, and thank you to everyone who's joining us tonight. My CNM partner, Stephanie, and I are going to talk to you about what midwifery care is, what we can do, and if this type of care is a good fit for you. So first, we're just going to introduce ourselves. I'm Jessica Braman. I am a nurse midwife in the Bloomfield, Oakland region. Prior to being a midwife, I was a neonatal ICU or a NICU nurse, and I worked both in Grand Rapids, Michigan and in Denver, Colorado. I completed my nursing degree at Michigan State University, so go green. I've been a midwife for 3.5 years, and I graduated from Frontier Nursing University with my master's in midwifery in 2018. And I've been with the IHA midwifery program since August, and since our program opened in Oakland in September of 2022.
Hi, everybody. I'm Stephanie Yaldoo. I'm one of the midwives in the Livonia office. A little bit about me is I've been in the birth world for about 7 years. I've worked as a labor and delivery nurse in multiple health systems in Southeastern Michigan. Some of my roles have been in nursing leadership. I graduated from Wayne State University with a master's in midwifery in 2020, and I've been with IHA since the program opened in Livonia in July of this year. So I just want to briefly kind of go over our overview tonight. Here's a little list of what we're going to be talking about. So let's talk about what midwifery is and what is a midwife. I want to preface this slide by saying this is really wordy, but we'll get into the specifics of who we are and what we do in the next couple of slides. Here are the technical definitions according to the World Health Organization. Midwifery is defined as skilled, knowledgeable, and compassionate care for childbearing women, newborn infants, and families across the continuum from pre-pregnancy, pregnancy, birth, postpartum, and the early weeks of life. A midwife is a person who, having been regularly admitted to a midwifery educational program, duly recognized in the country in which it is located, has successfully completed the prescribed course of studies in midwifery, and has acquired the requisite qualifications to be registered and/or legally licensed to practice midwifery. Let's talk about some of the history of midwifery. Midwives have been around since the dawn of time. There has been documentation of midwives in historical Egypt, China, and India. There's even mention of Hebrew midwives in the Bible. Phenerate, the mother of Socrates, was a midwife. But now let's focus on midwifery in the United States. Long before midwifery was a profession, granny midwives attended births in the southern United States, and even earlier than that, midwives were attending births during colonial times with knowledge passed down from midwife to apprentice while only having herbs and home remedies available to them. Let's fast forward to the 20th century. After the introduction of the nurse midwives into the United States in the 1920s, the legal authority to practice nurse midwifery was available in only a few areas of the country. But following decades of legislative action, nurse midwives now have the legal authority to practice and have prescriptive authority in all 50 states and U.S. territories. Since the profession's inception, midwives have cared for members of underserved populations, beginning with women and families in isolated and mountainous regions of Kentucky, impoverished women in crowded tenements of New York City, and women in rural and medically underserved New Mexico. Throughout the profession's history, midwives have continued to serve medically at-risk populations, and research has shown that midwifery care has provided benefits to those whom the profession serves. Midwifery today is a healthcare profession whose members provide care for women throughout the lifespan, with an emphasis on promoting and maintaining health. Modern midwifery is recognized locally as well as globally, with standards for education and practice that make it a profession rather than an occupation or vocation. There are 4 types of midwives, but we're going to compare certified nurse midwives and certified professional midwives. So certified nurse midwives have a graduate degree for certification. They hold a registered nurse licensure. They have programs that sometimes require 2 years of labor and delivery nurse experience. And they practice in all settings, home, hospital, but the majority of CNMs deliver in hospital. They're certified through the AMCB, which we'll get into in the next slide. And like I said before, they have authority in all 50 states and territories. Now let's discuss the certified professional midwife. They have a minimum educational requirement of a high school diploma. They have an apprenticeship with an established CPM where they do births. They practice primarily at home or at a birth center, and they are certified through the North American Registered Midwives, or NARM. And they have the authority to practice in 35 states. There's other midwifery disciplines that are not listed, but definitely worth mentioning. The certified midwife. This is an individual who has received a background in a health-related field other than nursing, and then graduated from a master's level of midwifery education program, like a certified nurse midwife. They have similar training to CNMs. They conform to the same standards at CNMs, but are not required to have the nursing component. Their license is recognized in 9 states and the District of Columbia. And then lastly, there's traditional midwives, and those are midwives who, for religious, personal, and philosophical reasons, choose not to be certified or licensed. They believe that they are ultimately accountable to the communities they serve, or that midwifery is a social contract between the midwife and the patient that should not be legislated at all. It's important for me to mention now that Trinity Health IHA midwives are certified nurse midwives. Now let's talk about accreditation and certification for midwives. So the ACME that I previously discussed is the Accreditation Commission for Midwifery Education, and they've been recognized by the U.S. Department of Education as an accrediting agency for our education program. The ACME makes sure that the quality of the education being taught to midwifery students meets the standard of care nationally. Standards of education nationally. For CNMs, this means that they have to complete their midwifery education from a university recognized by the ACME, and they have to pass an examination that measures mastery of fundamental knowledge needed to ensure safe practice. These are all required to obtain a license to practice and to obtain hospital privileges to care for our patients. In addition, CNMs must demonstrate that they meet the core competencies for basic midwifery practice in accordance with the American College of Nurse Midwives upon completion of their education program. ACNM competencies and standards are consistent with or exceed the global competencies and standards for the practice of midwifery as defined by the International Confederation of Midwives. These competencies happen every 5 years. This is really just a big way of saying nurse midwives have a formal education. There is a standard of care we must obtain and maintain, and this ensures that we practice the latest evidence-based care. I want to take a minute here to discuss doula care. Doulas and midwives complement each other during labor and birth, but there are some differences between us that I think can be a little confusing. So doulas are trained to provide physical, emotional, and informational support for a laboring person and their partner. A doula's duty is to provide continuous comfort, encouragement, and support, both emotional and physical, during labor. But how is a doula different from a midwife? Unlike an OBGYN or midwife, a doula does not have medical training. They're there to serve as a soothing voice of experience, help with relaxation techniques, breathing exercises, and offer advice on labor positions. Doulas don't perform medical procedures, which means they don't deliver babies, and they aren't permitted to prescribe medications. Since they aren't busy on the medical side of things, they're able to provide uninterrupted emotional support to moms and their families during labor and delivery. There are even doulas that specialize in postpartum support. They work on the maternity care team to improve birth outcomes and increase satisfaction with the birth experience. Birth doulas are vital. They're a vital part of the maternity care team. They promote physiologic birth. They attend to the non-clinical needs of the laboring mom, and they enhance communication within the relationships between the client and their midwife, physician, or nurse. I want to take a second here to discuss the art and science of midwifery. They're categorized into hallmarks. There are 17 of them. I don't feel the need to read all 17, but a couple stick out to me. So one of the hallmarks of midwifery is recognition, promotion, and advocacy of menarche, pregnancy, birth, menopause as a normal physiologic and developmental process. Advocacy of non-intervention in physiologic processes in the absence of complications. Incorporation of evidence-based care into clinical practice. Promotion of person-centered care for all, which respects and is inclusive of diverse histories, backgrounds, and identities. And empowerment of women and persons seeking midwifery care as partners in healthcare. You can find the full list of hallmarks on midwife.org. Let's talk about midwifery in Michigan. The first CNM practice opened in Michigan 42 years ago at Hutzel Women's Hospital in Detroit in 1980. Since then, the number of CNMs in the state has been steadily growing. There are currently 489 CNMs practicing in almost every area of the state. The state of Michigan requires nurse midwives to work with a collaborating physician to provide care for patients. A few things we collaborate with physicians are high-risk pregnancy, preterm birth, but as you'll find out, our scope is not just surrounding labor and birth.
Okay, so now that we have a better understanding of where midwifery originates from and what we can do, let's get into what we're about. Here's a brief look at our philosophy of care with our patients. So we believe that every person has the right to equitable, ethical, accessible, quality healthcare that promotes healing and health, healthcare that respects human dignity, individuality, and diversity among groups, complete and accurate information to make informed healthcare decisions, and self-determination and active participation in healthcare decisions. So these points are important to all members of the healthcare team, but as midwives, it's something that we're truly passionate about. Many patients interact with their healthcare provider and feel as though they're simply being told what to do. As midwives, we work very hard to promote something called shared decision-making, where you as the patient have equal or even more say in your care than we do. Our job as your provider is to educate you on your health and your options to help you better decide what's going to work best for you and your family. This comes up quite frequently during pregnancy and childbirth, where many patients have told me they almost felt bullied into a decision. As a midwife, it's my belief that once I've educated you on the risks and options, I can provide a recommendation, and sometimes that will be a strong recommendation. But beyond that, it's my job just to support whatever decision you make for your body, your family, and your life. We believe the best model of health care for a woman and her family promotes continuous and compassionate partnership, acknowledges a person's life experiences and knowledge, includes individualized methods of care and healing that is guided by the best evidence available, involves therapeutic use of human presence and skillful communication. Something that comes up so frequently during routine GYN care or care during pregnancy and childbirth is a history of sexual trauma. While I think you'd be hard-pressed to find a woman who loves a gynecology exam, the use of a speculum, the stirrups on an exam table, or even the act of giving birth can be so triggering to a woman with a history of sexual abuse or trauma. Our goal with midwifery is to put the power back in your hands by the use of trauma-informed care. Despite being in such a vulnerable physical position, we strive to make you feel and know that you are in control of what is being done to your body. Checking in with you during exams, minimizing invasive exams, stopping in an exam if you say stop, are just a few of the things that we do to help you feel as comfortable as possible. We honor the normalcy of women's lifetime events. We do this with watchful waiting and non-intervention in normal processes, appropriate use of interventions and technology for current and potential health problems, and consultation, collaboration, and referral with other members of the healthcare team as needed to provide optimal healthcare. This is vastly important, especially when it comes to pregnancy and childbirth. Letting your body do what it needs to do as naturally as possible and only intervening when needed and desired by you. Sometimes during the course of pregnancy or birth, things can go from low risk to high risk, and that's why we always have our physician partners available at any time to either consult, collaborate, or transfer care if needed. We'll get into more specifics of what collaboration or transfer entails later, but in the end, it comes down to getting you the safest, most effective healthcare we can. And with childbirth and pregnancy, ending with a healthy baby and a healthy mama is always the goal. So let's talk about some of the different spaces you may see a midwife, and we're going to start with the hospital. So it's not just out of hospital birth that we do. A common misconception when people hear midwife is that we primarily help deliver babies at home or in birth centers. In fact, in 2019, 89% of CNMs and CMs in the US attended births in the hospital, and this is compared to 9% in a freestanding birth center and 8% at home. At IHA, CNMs only attend hospital births. As with most things in midwifery, what you can expect at a CNM attended birth is a more hands-on approach to patient care. We work to be with our patients through their labor process and support them directly, not only be there to help deliver the baby. I like being a midwife delivering in a hospital because I feel as though we're able to provide a home-like environment and the type of support you would receive at home or in a birth center, but with all the amenities of a hospital if they're needed. So what might it look like or feel different if you have a midwife? A lot of times our patients, their labors in particular, look a little different than what you might expect or have seen on TV. A lot of times for comfort, our patients love to use the water, the shower, or the tub. They like to remain active during labor instead of being in the bed the whole time. And we encourage and allow different positions for delivery. I have delivered babies in all sorts of positions, not just laying on your back. I've done it at the side of the bed. I've done it in the bathroom. I've done it over the toilet. Wherever is comfortable for you, as long as it's a safe situation, we can deliver a baby there, I promise. When appropriate, patients will often receive what's called intermittent monitoring rather than continuous fetal monitoring in labor. So what that means is using a Doppler to monitor baby's heart rate at different intervals depending on what stage of labor you're in. And if continuous monitoring is necessary, we'll often use telemetry or a wireless form of monitoring so you can still move around and do what you want to do without being strapped to the bed. Priorities of our patients, a lot of times they like to deliver in a really calm, quiet space. They like delayed cord clamping, immediate skin to skin with minimal interruptions, and then early breastfeeding initiation. So another big misconception about midwives is that you can only have a natural or unmedicated birth to get care with us. And this is not true at all. While we do specialize and have special training that lets us support and assist you in an unmedicated birth, we can also support you if you choose to utilize traditional pain relief methods, like IV medications, nitrous, which is something that we can currently offer at our Ann Arbor and our Livonia locations, and hopefully coming soon to Oakland, and an epidural, which is probably one of the most well-known methods. If you know going into labor, you want one of these methods or all of these methods, or your plans change during labor and you decide you need some of these options to help you, we are there to support and guide you in that choice, and it does not exclude you from our care. Again, this is your body and birth, and we are there to guide and support you in your journey, whatever that might look like for you. So as CNMs, we work to utilize the most up-to-date evidence-based practice in our care. And it's been found that when women of equal risk status are cared for by a CNM rather than a physician, they tend to have lower rates of cesarean birth, lower rates of labor induction or augmentation. So labor induction meaning starting your labor when it hasn't started yet, and labor augmentation meaning if your labor started but needs a little boost during, like with medications or other methods. There's been a significant reduction in the occurrence of 3rd and 4th degree lacerations. So those are some of the deeper tears that can happen when you're delivering vaginally. Lower use of regional anesthesia or epidurals, and then higher rates of breastfeeding at 6 weeks postpartum. So as we've shared, there are so many benefits to midwifery care. However, not every patient is a good candidate for this type of care or can be managed by a midwife alone. So let's discuss what we can manage a little more specifically. It is important to note that each midwifery program will have its own careful set of guidelines which they follow. The examples that follow represent our process for Southeast Michigan regions of Trinity Health. So things we can manage or co-manage are things like TOLAC or VBAC. So that's a trial of labor after a cesarean birth or a vaginal birth after cesarean. And in 2021, our Ann Arbor region actually had a 75% rate of VBAC. So that's really awesome. We don't have data for Livonia or Oakland just because those are new practices. We can manage or co-manage things like gestational diabetes that are diet controlled, advanced maternal age, which is any woman delivering at 35 years or older, thyroid disease, most mood disorders, including depression and anxiety. And women with this history can actually really benefit from having the type of care that we provide, as well as preterm delivery between 34 and 37 weeks. Things that might risk you out of our care before or during pregnancy would be things like pre-existing diabetes, gestational diabetes requiring medication, chronic hypertension, which is high blood pressure coming into pregnancy, persistent placenta previa. So placenta previa, just to tell you a little bit about that, is when the placenta is covering or it's too close to the cervical opening. A lot of times this can be found at the 20-week ultrasound, and during the course of the pregnancy, it'll resolve on its own, but occasionally it stays there. And if that happens, a C-section is needed to deliver babies. So obviously that would require a transfer of care. Severe preeclampsia, preterm delivery prior to 34 weeks, or a multiple gestation pregnancy like twins, triplets, so on. So many of these physician management examples are things that might develop during the course of a pregnancy. In these cases, it's sometimes necessary for a patient to transfer out of midwifery care and into physician care right in the middle. When this occurs, it can be stressful for the patient and the family, not only due to the new health diagnosis in their pregnancy, but because they might feel like they're losing kind of some control over what they had planned for their pregnancy or for their birth, as well as losing the providers they'd really come to know throughout their pregnancy so far. I'd really like to stress the fact that at each of our locations, we have close collaboration and a great relationship with our physicians, which allow us to remain involved with the care of our patients in these cases. In some instances, women might end up needing a C-section for one reason or another, and that decision is made during labor. Most times in these instances, we as your midwife work so hard to be right there in the OR with you, so you continue to have our support, even if we aren't managing the delivery directly anymore. So this is just us kind of tooting our own horn here. We have some stats from our Ann Arbor region. In 2021, we had 450 deliveries and 389 of them were normal spontaneous vaginal births. 13% were C-section. Primary cesarean rate, which means the first time you've had a C-section, was 9.2%, and a repeat C-section rate, meaning not your first C-section, was 3.8. Like I said before, the VBAC or the vaginal birth after C-section rate was 75%, which is awesome. Our episiotomy rate, which is when a provider will manually cut the perineum during the delivery for one reason or another. This used to be done like routinely in the past. And since we've learned that for the most part, letting things happen naturally helps with healing. So we try to avoid it, but occasionally things are, you need to do it to help get the baby out and so on. So that rate was 2.6, which is great because it's quite low. Assisted delivery, which means a physician helped with the use of a vacuum or forceps, was 2.2%. So these stats are a reflection of the great teamwork of our midwives and the exceptional care our patients receive with our team. We don't yet have the stats for Livonia and Oakland regions as they just opened those programs within the last couple of months, but we're really hopeful that we're going to be able to emulate these wonderful stats from Ann Arbor. So now let's talk about midwives in the office. This is probably where people are the most, don't have as much information about us. They're very, you hear midwife, you think birth, and we can do so much more than that. And so let's talk about it. So we are more than just prenatal care. We love prenatal care, but we can do so much more. Midwives also provide well woman, reproductive, sexual, GYN care, and family planning services. We are recognized federally as primary care providers for individuals from adolescence throughout their lifespan, as well as a healthy newborn during the first 28 days of life. This means that from the time you get your period all the way through menopause, we can care for you. We conduct physical examinations and can independently prescribe medications, including but not limited to controlled substances. We can prescribe and administer different kinds of birth control, and this includes things like Nexplanon and IUDs, as well as promoting sexual health through STI testing and treatment if necessary. As one would imagine, given our work with pregnancy and childbirth, a large number of our patients do come to us during their reproductive years. We provide preconception, prenatal, and postnatal care to women, and this includes both physical and mental health. As was mentioned previously in my clinical interest, I have a really strong interest in perinatal and postnatal mood disorders, such as postpartum depression or depression during pregnancy. And we work really hard to help these women get the support they need. Sometimes that just looks like some emotional support during visits. Sometimes it looks like referrals to therapy, and sometimes it looks like exploring medication options. These are all very individually based and on patient needs and situation. We also see many women who struggle with abnormal uterine bleeding or irregular periods, as well as frequent vaginal infections outside of STIs. We can work with you to do initial workups and treatments, and if we can't solve your problem, we have our physician partners there to help if needed. So now let's talk briefly about the difference between an OB and midwifery care. So a midwife has at least a master's degree in nursing. Some have doctorate in nursing practice or a PhD in nursing as well. We specialize in low-risk GYN care and low-risk pregnancies, and actually 85% of pregnancies are actually considered low-risk. And we are experts in low-risk normal birth processes. OBs, on the other hand, hold a medical doctorate degree, so an MD or a DO. They specialize in high-risk GYN care and high-risk pregnancies, and they are experts in surgery. So many factors are accounted for when selecting a provider: patient preference, medical history, risk status, just to name a few. And this comparison is not meant to be an us versus them. our OB partners are one of our most valuable resources when caring for women in and outside of pregnancy. Midwives are experts in low-risk physiologic labor and birth, and our physician partners are there for us and our patients when something falls outside of our scope of practice. Both specialties are needed and have a place in the world of women's health, and it's when we use our individual training and strengths together that we provide the best care for our patients. So all this is to say that we need each other. We are a team. Optimal outcomes for patient care and birth are achieved when certified nurse midwives are working in conjunction with supportive physician partners, and this is exactly what you're going to find with IHA Midwifery. Now to the question you're all wondering, is a midwife right for you? The answer is essentially yes. If you are a person who has gynecologic needs and is looking for inclusive healthcare, we are right for you. I do want to give a special mention to those members of the LGBTQ+ community, including those who identify as transgender, as this community is very underserved in the medical world and often aren't sure where they can go to seek non-judgmental, unbiased, safe healthcare. If this community describes you, I want to encourage you to consider making midwives a part of your healthcare team as well. If you are a person with a low-risk pregnancy or in need of low-risk gynecologic care, we are right for you. And in the end, if you come to us and your needs end up falling outside of our scope of practice, we will work with our physician partners to get you the treatment and the care that you need.
I just wanted to take a minute to share some comments from the community regarding the care they receive from the nurse midwives at IHA. So this one is about Nicole. Nicole was absolutely fantastic. She sat down and made me feel like she had plenty of time for our visit. She is thorough and is incredibly knowledgeable. It can be uncomfortable to talk about one's private and reproductive health, but she completely put me at ease. I never felt rushed, and I even walked away with more answers than I realized I had questions for. I also appreciated that during the physical exam, she explained everything that she was doing and was gentle, but again, very thorough. Here's another one from Livonia. I received care through the IHA Midwives Livonia this time around and would highly recommend them to anyone looking for a midwife. And lastly, I have continually been very happy and impressed with the care I've received from IHA Midwives. Just wanted to highlight our locations. So Trinity Health, IHA Nurse Midwifery is available at several offices in Southeastern Michigan. There are 17 midwives servicing Ann Arbor and Chelsea, with deliveries out of Trinity, Ann Arbor, or St. Joe's. There are 3 midwives, myself included, servicing the Livonia area with deliveries out of Trinity, Livonia, or St. Mary's. And there are 3 midwives, including Jessica, that are servicing the Bloomfield Hills, Oakland area with deliveries out of Trinity, Oakland, or St. Joe's, Oakland. All of our certified nurse midwives have graduated from accredited programs and are individually accredited through the AMCB, or the American Midwifery Certification Board. And some of our midwives have doctoral degrees and teach the future midwives at the University of Michigan. Here is more information on our offices with phone numbers where you can connect with our staff. Jessica and I would like to personally and sincerely thank you for your time and attention this evening learning about midwifery. The IHA Nurse Midwives would be honored to have the opportunity to care for you and your family. Thank you very much.
Okay, thank you both so much. And definitely I will include all of this information in our follow-up email, but feel free to grab a screenshot or jot down a number if you'd like to do so now. But if not, you will receive it in just a couple days. Okay, thank you both. Are you guys ready to answer a few questions?
Sure.
Awesome. Okay, so it looks like our first question was asking if you could go over what it means to be a CPM one more time.
Sure.
Let me see if I can find. Give me just one moment. I might click on the wrong slide. So give me just
no
a
problem.
Slide 7. So the CPM is sort of what you hear in the community. You know, when somebody says I'm using a home birth midwife, it's typically a CPM. And just to, you know, reiterate, they have an apprenticeship with the CPM. They do births at home, but they're different from a CNM, which is what IHA, the nurse midwives at IHA are CNMs. And the big difference is education and the setting in which we deliver in. Now we can deliver at home if that's something that we're comfortable with, but I think that, you know, most CNMs deliver in a hospital. And like I've said before, IHA nurse midwives are all CNMs.
Okay,
Hope that answers your question.
yeah, thank you. Okay, let's see. So someone is asking, are episiotomy rates higher for VBACs or managed by OB-GYNs?
Can you repeat that question one more time?
Yes. So are episiotomy rates higher for VBACs managed by OB-GYNs? So if a VBAC's managed by an OB-GYN versus a midwife, are you more likely to have an episiotomy?
So I'm not going to have an exact stat for you, and I wouldn't think you would be more likely to, and correct me, Stephanie, if you feel differently than this, I wouldn't think you would be more likely in either's care necessarily to have an episiotomy during a VBAC birth. And to be honest, it all depends on the physician that is caring. If you're with an OBGYN, occasionally some of the more seasoned doctors tend to kind of, because that's how it was done so routinely back like years ago, some of them are just very much in that habit and might be a little more apt to use that quicker than say a midwife would, or even a newer doctor, just because of the evidence that we've seen. But in terms of the VBAC or a TOLAC birth versus just a person who hasn't had a C-section and giving birth, I wouldn't anticipate you needing an episiotomy any more than anybody else. I hope that answers the question.
Sure. Yeah, it sounds good. Okay. So if somebody isn't sure who they want to see, whether it's an OB-GYN or a midwife, are they able to meet with both during pregnancy and maybe make alternating appointments with a midwife and an OB-GYN to kind of determine what they think will work best for them?
I think that's appropriate to do a consultation. If let's say we have somebody that's seeing the physicians and then just realize that, you know, example for IHA Livonia, they just realize that we have nurse midwives. It's absolutely okay for them to schedule a consultation with us. We'll talk about who we are, what we do, what we can offer. And if the patient wants to transfer, it's very smooth. And that's vice versa. You know,
Yeah.
Of course, like a midwife maybe isn't right for you and you want to stick with your OBGYN, that's totally okay.
Mhm.
We can also transfer to them. It's back and forth. It's okay.
Okay, and that was one
Options.
question as well. So if you're with your OB-GYN and then maybe you're learning more and more about midwifery and think it might work for you, you can absolutely come from an OB-GYN to a midwife.
Yes.
Or even later on. Okay, perfect.
Mhm. It's very common, actually. And it's not to say that there's anything wrong with the doctor you're seeing, just a lot of times women aren't aware of midwifery or that it's offered in their area. And then they kind of realize, well, that's actually the type of birth I'm looking for or the type of support I'm looking for. And yeah, we do it all the time. We take transfers.
Okay, perfect. And so the first step in initiating a conversation or meeting with a midwife or consultation, should they go through their OB office or can they contact a midwife practice directly?
I would recommend contacting the midwife office directly to set up that consultation. You can always ask your OB if they have if they're associated with a midwife practice, but it's probably a little easier if you go straight through us, just because we work together. It's a little confusing. We work together, but we are separate practices. So to get a more straightforward, like write-in appointment and talk to people who like schedule for us and all that, I would say contact one of our offices directly.
Okay, great. And again, the contact information is up on the screen now, but we will also include it in the coming days in our follow-up email. So I made a mistake in the question I asked about episiotomy, she had VB, so I assumed VBAC, but she was actually asking about a vaginal birth. So she wanted to know, is it more likely that you'll have an episiotomy with a vaginal birth versus, I'm sorry, with an OB-GYN in a vaginal birth versus a midwife in a vaginal birth? Does that make sense?
Yes.
Okay.
Overall, I'd probably say midwives are much less likely to use an episiotomy, period. Many, especially the new, like I said, especially the newer docs are like much more immersed in like the latest data and information and evidence based on episiotomies or not, but some doctors might, and I don't want to speak for all doctors here, some OBs might be a little more loose with the use of episiotomies just because they're also surgeons and they can sew it right back up. They have no concerns. Midwives can suture things as well, but we're very focused on the natural way of things. And so we really try to let your body do its thing unless we absolutely like have to perform one of those types of techniques.
Okay, excellent. Do any of your patients have a history of miscarriages?
Yes, we see a lot of patients who have a history of miscarriages. We counsel patients through miscarriages. Caring for somebody who's actively going through a miscarriage is absolutely within the scope of a midwife.
And I think sometimes women really almost, in a terrible situation like a miscarriage, almost appreciate our care just because we tend to be really pretty personable with our patients, and really we have more time. We specifically schedule longer visits with our patients so that we really have that one-on-one time with you. And I know personally, and I believe Stephanie practices and all the midwives in our program, like we're there to be with you during these like hard and wonderful moments. And so we want to give you all the support that we can.
Yeah, I think the word compassion comes up on a lot of bios when I read them for midwives, and it definitely seems to ring true. Do CNMs run the same pre-pregnancy tests as an OB-GYN would? I'm not sure exactly what kind of pre-pregnancy tests we're talking about. I'm not sure if there's a standard routine that you guys have, or if that's maybe it's for special cases or maybe high risk.
They're probably referring to labs and
Okay.
like just routine testing. And I'd say for the most part, yes. We do. We have our initial workup that we do. We try to avoid unnecessary things, but we also want to provide the safest care that we can. And a lot of that, like there's blood work and testing that we recommend and all that kind of stuff. So that part, like during pregnancy, looks very similar, I'd say, to an OB in terms of like what tests we would be asking you to complete.
Okay, great. There's a question about a birthing center versus a hospital. When might you give birth in a birthing center versus a hospital? Is there ever a reason you might want to do that?
I think that it's patient preference. I think if a birthing center is something that you're interested in, of course, that would, maybe if somebody that's low risk wants to deliver there. I'm not sure of many birth centers in the area, but just to reiterate, the nurse midwives at IHA deliver in the hospital. I believe this wholeheartedly, that we can provide that birthing center experience for patients with the comfort of the amenities that a hospital can provide. If you're looking for specifics like, hydrotherapy or tubs or the nitrous, or, those are all things that are available to us. Or if you're not looking for anything and you want to not have any pain management, or you want to, do certain types of pain management like hypnobirthing, we're flexible. We can take care of the whole spectrum of labor and birth.
Do you want to touch on a little bit about what the environments are like inside the hospital? I mean, I've had children myself, and they definitely don't feel like a hospital when you're in there, in a a labor room. It can feel very warm and cozy, and kind of can be whatever you would like it to be, it seems.
Yeah, I guess I can only speak to St. Mary or Trinity Livonia, also known as St. Mary's. But we offer nitrous, we offer anesthesia like epidurals, we offer IV pain management. And I just delivered somebody yesterday who was completely natural, nothing. And she was intimately monitored. The nursing care at St. Mary's is wonderful, as they are at all Trinity hospitals, because it's one-to-one care. Like, the nurse doesn't have other patients. You are the main focus of the midwife, the nurse. You're able to have your support person there. We do allow doulas. There are multiple things that are available to you, like peanut balls that can help open your pelvis. We recently got these cubs, and the cub CUB is like a U-shaped cushion, and it's really great for leaning over and squatting. We're working on getting tubs. We're getting that approved, and we have showers. We're in the process of getting wireless monitoring if you're somebody that requires continuous monitoring, or those belts. Yeah, those are the things that we offer at Trinity Livonia. I don't know if you can speak to Oakland, Jessica.
So we have very similar, and our unit is actually currently about to be completely renovated and redone. So that's really exciting. But pretty much everything you mentioned in terms of the positioners and the balls and all the things, shower access, that kind of thing. We do have that currently, and we'll continue to have that once it's renovated. It'll just be a little fancier.
And you're allowed to bring things from home, right? I mean, within reason, I assume, but you're allowed to sort of make the room feel like your space when you're there.
Absolutely. Yeah. Absolutely. Whatever you need to comfort you, absolutely you can bring. No candles though. That's the thing you can't bring.
Yeah, no candles. You can bring, I think, the battery powered votives. But I've had patients bring little speakers, play in music or what have you. I've had them bring little aromatherapy. Just a side note, what I always recommend my patients bring is a handheld little fan. So your husband doesn't, or your partner doesn't have to be there fanning you with a sheet. Okay. Bring a fan, you'll want it, you'll be hot. That's what I say.
So it sounds like you can really make the birth your own, which is so cool. Okay, there are a couple of gin questions. So typically I think we think of a gynecologist as we have an annual exam, and we do that once a year, and we kind of don't see them unless something is wrong. So is that similar to what a relationship would be like with a midwife? And I know you talked about managing even medications or therapy. Is that something that you would continuously do throughout the year? Again, is it just like you would have your check-ins once a year, your pap smears, or your tests, or whatever maybe?
Yeah. As long as nothing, obviously, if anything is happening between those yearly appointments, then that's you come see us for problem visits. But other than that, we can be your yearly provider. I have many patients that come to me once a year, and we keep their paps up to date. We make sure their birth control is working well for them. We do a full assessment, and then if anything is falling outside of really our wheelhouse, say they were having a lot of issues with their asthma or something that they normally see their primary, then we will refer them out to their primary for those type of issues. But for your gynecological reasons that you go see an OB/GYN for, that's just routine. That definitely is care that we provide.
Perfect. And if you choose a midwife for your gynecological care, do you need to have an OB/GYN as well, or can a midwife be your only person in that position?
If you are low risk and not having sorry, didn't mean to cut you off, Stephanie.
No,
not having crazy issues, then by all means, we can be your main provider.
Awesome. I'm just reading through this. It's a longer question, so I'm just going to read this word for word. I'm very inclined towards the midwife route, but the OB/GYNs all have many reviews with high ratings, whereas there aren't any patient comments about midwives in the same clinic. How do you recommend us choose a midwife in the absence of such information? So I think they're talking about on the IHA site. Yes. And some of our midwives are, like you said, the programs are newer.
Mhm.
So we wouldn't have accumulated reviews for our newer providers in the newer programs. Do you want to touch on that in any other ways, or anything else you can recommend?
So, I mean, and Stephanie, you can speak to this too. One thing I'd say is, like Stephanie talked about some of the testimonials that like our Ann Arbor group has many many reviews and midwives because they have sorry, my managers are giving me the information for me to tell you. So the Ann Arbor region has been around longer than Livonia and Oakland. So those midwives have lots and lots of reviews. And what I'll say is IHA is hiring women or midwives, not just midwives, can be male as well. They're hiring midwives of all like-minded type. So if you can kind of get a basis for like what IHA looks for in a candidate when they're doing a hiring process for a new practice. And I would say for the most part, it's very reflective of what the rest of us do. Beyond that, sometimes, and this happens with, I know there's reviews for OBs and things, but sometimes an OB can, or any provider can have a great review and you get in there and that person just doesn't mesh with you. And that isn't a bad reflection of the person or a bad reflection of you. It's just like personal preference. So sometimes you have to trial it and come and see if you really click with that practice or that person. And if it doesn't work, it doesn't work, and you're not going to hurt our feelings. We want to get you the care that you want and that you need. And so if it isn't a good match, then we want to find you the match that is right for you.
I just want to say that much of the lack of reviews has to do with the fact that the IHA nurse midwives provide group care. For example, like you come to Livonia, you're going to see me, my partner Nicole, and my partner Katie. We're newer, so you're not going to see a lot of reviews for us in Livonia, but Ann Arbor has been voted the top nurse midwives in Ann Arbor for many years.
Yes, and I will say, from my perspective, the midwife program is growing so much within IHA, and it was so exciting this year to be able to deliver in Livonia and Oakland with our midwives. So it is definitely growing, and you can always do a consult to see how you feel about the person that you've chosen. So, and we do have programs in Oakland, the Livonia area, and in Ann Arbor, and you really have you have a lot of places to choose from in the 3 different hospitals. So it's just growing by leaps and bounds, which is great.
Yeah, I just want to comment one more thing, that let's say you're seeing an OBGYN outside of IHA, you don't need their permission to come have a consult with us. You can absolutely call our office. It would be helpful if you had your prenatal record, but if you wanted to transfer and have midwifery care, you don't need anybody's permission.
Okay, perfect. Okay, so I think that's all of the questions we have. Is there anything else you guys would like to share or you think would be helpful?
I'm just so happy we had the opportunity to really speak about midwifery and kind of expand people's knowledge on it, because it's really been growing and growing and growing, but still there's so many people that just don't know everything we can do. So I really am thankful that you all showed up tonight, and I hope that we were able to teach you some things about us.
Excellent. There was one more question. So apparently there's an award-winning show called Call the Midwife. Have either of you heard of it? This person said, is it accurate? Because they love that show. Have either one of you seen it?
I read the book, and then and I have read, yes, I think it was on, it might have been BBC or something. It's a very good show. It's about midwives, like back in the day, like they're riding bikes to births. And no, I actually really like watching it because the patients will, like in the story, will be having symptoms and I'm like, preeclampsia, she's got preeclampsia. So I mean, we're not riding bikes to the hospital, for the most part, I'd say, but yes, the type of like care, the one-on-one care and the supportive care, that is definitely accurate.
Awesome. All right. Well, thank you both so much. This was awesome. I loved hearing about all the aspects of midwifery care. And we just appreciate you both taking your time to educate us. And again, we will share this wonderful presentation through the recording in the next couple of days. And if you at any point would like to consider bringing a midwife into your care team, you can contact their practices directly. So thank you both so much. Have a great evening.
Thanks, guys. Take care.
Thank you.
Bye.